Hi, everybody. Good evening, good afternoon, good morning, wherever you are. It's a great pleasure to deliver today this special IACH webinar dedicated to the latest advances in multiple myeloma, a post-ASH 2020 summary. Actually, we have started this tradition since 2018, and every year, as part of the International Academy for Clinical Hematology webinars, we have in December and January different webinars dedicated to the most important topics discussed during ASH 2020. And actually, when it comes to multiple myeloma, this ASH has been really a fascinating Congress. Obviously, it had a different flavor because of the digital virtual format, but still, I think we can congratulate the ASH, the American Society of Hematology, and the staff and all the participants for delivering an absolutely fabulous meeting. As a matter of fact, we have all missed the in-person interactions, and hopefully we'll be able to come back to these in-person contacts because nothing can replace them. So for the next few minutes or so, like in previous years, I thought to give you a sort of an overview of what I personally consider as the most important or practice impacting from ASH. I do apologize in advance for the sake of time. I may not be able to go into all the details. I may have missed some other important presentations, and I do apologize to the authors and co-authors. But definitely, we will be able to take questions, to have a discussion at the end of my talk, and all you need to do is to send your suggestion, your questions, your comments using the chat box. These are my disclosures relevant to this talk. However, the work has been exclusively prepared by myself and reflect my personal choices. For the sake of introduction, I wanted to start with this slide presented during ASH. I forgot, this is why, who presented it. I do apologize. This is why there's no reference, but I think this is really a very popular slide showing the different key steps when it comes to the natural history of multiple myeloma. And my speculation and best guess is that the treatment of multiple myeloma is going to be dramatically modified, not only in the frontline setting, but also at time of early relapse, but also late relapses in the relapse refractory setting. So definitely in the frontline transplant eligible patient, quadruplet-based induction are being more and more well established for the future standard of care. The maintenance and consolidation fields are moving also rapidly. When it comes to the elderly non-transplant eligible population, you will also see that there are some very meaningful advances. In terms of relapse, it's a true fireworks of innovation and new agents, not only playing with the available drugs and trying to figure out what are the best combinations based on the approved drugs, but also we have now brand new agent, new classes, especially in the field of immune therapy, with, I believe, three pillars: the cellular therapy, especially CAR T cells, which are coming now very quickly, I think, into more and more into routine practice. We do have also the bispecific antibodies, which I consider as one of the major highlights of this ASH 2020. And of course, we have the advent of this new family of drug conjugates, and I'll come back later to these different agents in a few minutes. I tried to structure the summary in a very traditional way: transplant eligible, non-transplant eligible, relapse refractory patient. Transplant eligible patient. This ASH has been dominated, in my opinion, by three major presentations, clearly establishing the power and role of autotransplant in young multiple myeloma patients. The first study I'd like to summarize is the so-called Forte trial presented by Dr. Francesca Gay from Torino in Italy. This trial has been presented during previous ASH meetings. Here we had a very nice update, but also mature outcome data. I would kindly remind you that this is a randomization between KRD, let's say long treatment, no transplant, KCD induction followed by transplant, consolidation, and maintenance, or KRD induction followed by transplant, consolidation, and maintenance. And the key findings from this Forte trial are shown here, clearly demonstrating the advantage of a KRD-based induction, carfilzomib, lenalidomide, dexamethasone, followed by auto-transplant. This is the blue curve you can see here, including a high level of MRD negativity. Also, the new and I think important information from this trial is about the benefit of a doublet, actually maintenance treatment with carfilzomib and lenalidomide. Traditionally, and the standard of care is about delivering lenalidomide maintenance therapy as a single agent. Here we have a proof of concept that actually a doublet combination for maintenance can be beneficial in terms of progression-free survival. The second auto-transplant study, which has been also a highlight in my opinion, is this EMN, European Myeloma Network 02HO95 study. This study also has been presented at different occasions and congresses, and here we have a nice update. Again, as a reminder, this is a VCD induction protocol, bortezomib, cyclophosphamide, dexamethasone, followed by melphalan delivered, in a gentle manner in a VMP regimen, the famous historical VISTA regimen, bortezomib, melphalan, prednisone, versus high-dose chemotherapy with melphalan, followed by consolidation and lenalidomide maintenance. These are the key findings from this study, where you can appreciate that the second PFS, so PFS2, this is PFS from time of first relapse, but also actually time to next treatment were significantly extended with auto-transplant compared to the VMP upfront. So another study highlighting the powerful impact of high-dose melphalan for disease control. And interestingly, although this is usually quite rare in the field of myeloma, we do see clearly an overall survival advantage. So this study, in addition to the previous 40 trial, is adding an additional piece to the puzzle. Of course, one can argue about that the fact that VCD or VMP are weak regimens. Still, this is a nice proof of concept, and you can appreciate further in this study that a consolidation with VRD after transplant is definitely an important step towards improving PFS. And this is in contrast to what we already knew from the previously published Stamina trial from the US, showing no benefit for consolidation. But I think the story is more about what do you use for your induction, and obviously your consolidation will have an impact depending on the initial choices. The third transplant trial, which was presented at ASH with a long-term follow-up, this is the IFM 2009 trial published a few years ago in the New England Journal of Medicine. And Dr. Perot from Toulouse actually updated the trial. You can see on the left-hand side the design of the trial. This is a true transplant versus no transplant comparison. VRD on one hand, VRD is viewed as a very good combination versus in arm B, VRD induction high dose melphalan. And with more than 8 years of follow-up, you can see the progression-free survival advantage in favor of the transplant arm. And here you can see another important piece of information in relation with MRD negativity impact. Definitely being MRD negative is going to correlate with a good outcome. And interestingly, the MRD negativity rate and depths are better in the transplant arm. So this is clearly an important information further supporting the value of auto-transplant frontline. And these are the conclusions of the presenter, Dr. Perot, which of course I personally share and fully agree that high-dose melphalan with transplant significantly reduce the risk of progression or death compared to VRD alone. We do have 8 years follow-up, so this is quite decent, and 60% of the patients are still alive in the two arms. So this is really another important information to patients and families. And this is totally different to what you could see in all textbooks or on the internet sometimes. We believe that frontline transplant should remain the first choice for these patients. And actually, if we're talking about the topic of cure, at least functional cure, one can appreciate that 1/3 of these patients, 35% in the transplant arm, didn't relapse after 8 years of follow-up. Therefore, we believe that delaying transplant in first relapse could be an option, but only in exceptional circumstances, because this is really a useful treatment, more MRD negativity. And actually, the question, in my opinion, is not about transplant versus no transplant, but actually, how can we combine a transplant and the most effective combinations like the quadruplets in order to synergize and further improve the outcome of these patients. And this is exactly actually the spirit of the update we have seen about the Griffin phase 2 randomized trial, which was published actually a few months ago in Blood. And here we have an updated analysis after maintenance. And this is about a quadruplet induction with daratumumab, bortezomib, lenalidomide, dexamethasone, dara, VRD. And to make a long story short, this kind of regimen followed by transplant consolidation and maintenance can allow patients to achieve a very impressive rate of MRD negativity. But actually, it's not only about MRD negativity, but also it's about sustained MRD. And you can see that more than 37% of the patient had a sustained MRD more than 6 months, and 29% roughly had it after 12 months. So clearly, we can see the roughly 30% of the patient being in MRD negative, and these are likely the patient that will enjoy long-term survival and long-term outcome. Similar to the 40 trial, this study is suggesting that a doublet actually induction daratumumab and lenalidomide can be interesting, and in the near future, I think we are eagerly waiting for some of the trials looking into this kind of combination with daratumumab and lenalidomide for maintenance after transplant. I'll move now to the elderly or non-transplant eligible patient. I think this space of non-transplant eligible patient therapy is still, I think, completely dominated by the amazing results of the MAIA trial that was published by Professor Facon a couple of years ago in the New England Journal of Medicine. This is a randomized trial comparing the standard of care lenalidomide dexamethasone to daratumumab lenalidomide dexamethasone. And here during this ASH, we do have a mature long-term follow-up, and you can appreciate that 60% of the patients are still progression-free survival at 4 years. And we are talking about a population with a median age of 73, 74 years. This is clearly an elderly population, and these PFS curves continue to separate with time. And actually, this PFS benefit was consistent across all subgroups, including the high risk cytogenetics patient. And this improvement is probably in relation with a high overall response rate observed with DARA-RD, but also again, it's coming more and more, I think, into this in the myeloma trials, into a high rate of negative MRD, but also sustained MRD negativity. So clearly, sustainability of MRD negativity is a keyword from ASH 2020, and because this is in correlation with the improved outcome. The other approved regimen in the elderly non-transplant eligible population is the Alcyone trial, DARA-VMP, daratumumab, bortezomib, melphalan, prednisone. And this trial has been published several times. There is even an overall survival advantage for this quadruplet combination. What we have seen, and I have selected from this ASH, is the presentation about the quality of life. Because when it comes to the elderly non-transplant eligible population, you may have a highly effective regimen, but then you have to consider what is the impact in terms of safety and quality of life. So here we have some good news that deepening the response using a quadruplet regimen in an elderly population actually is not impacting negatively the quality of life. In contrast, you have a clinically meaningful improvement in quality of life. And when we put together, and that was another presentation by Dr. San Miguel, the MAIA and Alcyone data, I think the key message is about the durable MRD negativity impact on outcome. And I think we have to watch out in the next few years for this important endpoint, which is the MRD negative, the sustained MRD negativity, because definitely these patients with sustained MRD negativity, although we're talking about elderly patient, you can appreciate the impressive outcome they are enjoying. Regarding the elderly population, we had during this ASH 2020 virtual meeting a very nice presentation by Professor Facon regarding the Tourmaline MM2 trial. This is another randomized trial comparing standard of care Lendex with ixazomib Lendex. Ixazomib, second generation proteasome inhibitor, oral drug. So you have a full triplet combination, I would say, very convenient. And this is a really very elegant study, but the interpretation is a little bit complicated because the glass is half full or half empty. The trial didn't achieve its primary endpoint from a statistical point of view. However, there is a clear progression-free survival advantage with ixazomib Lendex, 35.3 months versus 21.8 months for lenalidomide dexamethasone alone. So from a clinical standpoint, I think there is clearly a benefit because the difference is there, 35 versus 21. From a statistical point of view, it's a bit disappointing. However, I believe this regimen can be of value for many elderly or non-transplant eligible patients. I think it's always good to have a choice and to try to personalize the treatment for those frail patients, especially during this COVID-19 pandemic. Let me move now to the treatment of patients with relapse refractory myeloma. And here, as I mentioned in my introduction, it is amazing. I think it can take us several hours to go through all the different presentations, but I needed to make some selections. Sometimes they are not ideal, but definitely we need to do them. I selected this so-called DARIA trial because I thought it's a very useful one given the COVID-19 pandemic, but also given what we know from the CASTOR randomized trial about the value of daratumumab, bortezomib, dexamethasone, Dara-Val-Dex, which is approved, I think, worldwide and used in many patients. So the question here, can we replace bortezomib by ixazomib, which is another proteasome inhibitor, second generation oral drug, so making it more convenient to many patients. And this is a single arm trial, but then you can appreciate that this combination is leading to some interesting response rate. Obviously, it's a single arm, so it's difficult to make a comparison, but I think it's a good start and it's a good option in some selected patient with who needs a combination of daratumumab and ixazomib. The other relapse refractory combination which was updated at ASH is this famous now CANDOR protocol. This has been published in the Lancet during the last few months by Dr. Dimopoulos and Dr. Usmani. And remember, please, this is a very attractive combination comparing daratumumab, carfilzomib, dexamethasone to carfilzomib, dexamethasone, another approved combination, remember, based on the Endeavor trial. And this is an extremely useful combination, especially if you don't want to use an Imid or if patients are already resistant, for instance, to lenalidomide. And the good news we have here is that with longer follow-up, you can see the shape of the progression-free survival curves, which is clearly separating. So the triplet DARA-KD is extremely useful in these patients, and you can see that the hazard ratio is around 40% improvement in these patients who received between 2 or 3 lines of prior therapies. Daracarfizumab dexamethasone is an option, is approved now in many places, but we should not forget that we have also another anti-CD38 monoclonal antibody, namely isatuximab. So isatuximab has been tested in the so-called IKEMA trial, comparing isatuximab carfilzomib dexamethasone to same regimen carfilzomib dexamethasone. And actually, similar to the DARA-KD, this triplet combination of an anti-CD38 plus KD actually is proving to be a powerful salvage regimen. And what I have noticed in the presentation of Dr. Martin during the ASH is the outcome of those patients who are MRD negative. This is really amazing, a sort of a flat, a plateau, which is definitely good news for many of these patients. So clearly, the combination of carfilzomib dexamethasone plus an anti-CD38, whether daratumumab or isatuximab, is making a difference in the life of these patients. And you can see that with the isatuximab KD combination, you can appreciate the high level of MRD negativity one can see in these patients. And I hope more and more patients will be able to get access to this kind of regimens. Well, you may ask whether we need to give a proteasome inhibitor to everybody, and you may wish to give an Imid. So why not combining an anti-CD38 plus an Imid like pomalidomide? And the idea people have in mind is how to salvage those patients who are resistant to lenalidomide. A couple of years ago, and it is now approved and widely used, we had the ICARIA randomized trial comparing isatuximab pomdex to pomdex. Isatuximab, same antibody I mentioned for the IKEMA trial. During this ASH, we had for the first time the first results of the Apollo phase 3 randomized study comparing daratumumab pomalidomide dexamethasone to pomalidomide dexamethasone. I kindly remind you that darapomdex is actually approved in the US and is being used based on phase 2 data. However, we were lacking phase 3 data. The phase 3 data we had were with isatuximab pomdex. And now, thanks to this Apollo trial, we have results of a phase 3 trial, and you can appreciate very nice PFS curve with Dara pomdex compared to pomdex alone, a hazard ratio of 0.63, and majority of these patients were refractory to lenalidomide, and 30% had high-risk cytogenetics. So this is clearly a very useful and important option that will be, in my opinion, more and more used worldwide. Of course, maybe not everybody has access to carfilzomib or to pomalidomide, or maybe for some reasons you would like to avoid these drugs and rely on alkylating agent. And we know that across the globe, many people are still keen on using alkylating agent, and these are definitely important drugs for the management of multiple myeloma. I started initially showing you the value of high-dose melphalan, but we also know that low-dose melphalan or low-dose cyclophosphamide are also useful. They are relatively cheap, easy to use, can be used in an ambulatory fashion. So I was pleased to see during this ASH, this presentation, actually combining daratumumab, cyclophosphamide, and low-dose dexamethasone, plus or minus pomalidomide. But my focus and what attracted me here is the combination with cyclophosphamide. And definitely, this combination is feasible, can be very useful in many patients, and the overall response rate is almost 90%. But if you are really very keen on using alkylating agents, well, the future can come very quickly, actually. And you may wish, actually, to explore a new generation of alkylating agent, namely the peptide conjugates. And the first in class is melflufen. And by the way, you may have seen last week the publication in the Journal of Clinical Oncology about the Horizon study combining using melflufen. Here, during ASH, we had, and Dr. Ocio, Enrique Ocio from Spain, presented the first result of the ANCHOR trial, looking into daratumumab plus melflufen and dexamethasone. Of course, this is a phase 1/2 open label, but multi-center, and these results are definitely very attractive because melflufen, which has a much better safety profile compared to melphalan, although you may not be able to compare because this is really a second generation agent, totally new family of drugs. Definitely melflufen can be combined with the anti-CD38 antibodies and can be very well tolerated. Going back to the Imids, we spoke about lenalidomide, we spoke about pomalidomide, and these two Imids are really were really a breakthrough in the field of multiple myeloma. These are really pillars of the treatment of multiple myeloma worldwide. Well, during this ASH, we've seen the presentation about a new generation of Imid, now we call it cell mode, namely iberdomide. Iberdomide is much more potent than lenalidomide or pomalidomide, higher efficacy. Probably we still need to see more data, more follow-up, more patient, but probably rather safe. And apparently, according to these results presented by Dr. Niels van de Donk from the Netherlands, iberdomide can be combined with daratumumab or bortezomib and dexamethasone, again in a very heavily pretreated population, median 4 to 6 lines of therapy. So I would kindly ask you to watch out, to look for iberdomide, because this drug will really be another pillar of myeloma therapy, in my opinion, in the near future. But the future is also about cellular therapies and immune therapies. And again, as I mentioned in my introduction, I think we can divide this into 3 major compartments: the CAR T cells, the antibody-drug conjugates, but also the bispecifics. And I personally believe that these bispecifics were really one of the highlights, if not the highlight, of ASH 2020. And actually, if you are interested in history, I managed to find in my archives this photo from the ASH News Daily. Remember, this is the journal that was distributed in the morning when we were attending ASH as an in-person meeting. And in December 2016, you can see the title, Breaking Waves in California, Novel Immunotherapy for Multiple Myeloma. Of course, we'll not have time to read it together. I can send it to you if you send me an email. Nevertheless, everything that we have seen now actually started to be discussed 3 years ago. However, my understanding from the discussion that it may take us maybe 10 years to get to it. And in less than 3 years, it's already there. It's already there. Amazing, fabulous. CAR T cells. You are quite familiar, I think, with BB2121 construct. This is the New England Journal of Medicine publication last year by Dr. Nupur Raj, about 33 patients. Now we have the large multi-center study, the so-called KARMA study, which has included more than 100 patients, actually 140 patients. And the interesting, of course, this has been already presented in other meeting. The good news, and I like it, we have a name now for BB2121, ID cell. And they have analyzed, the authors analyzed response rate by subgroups, and whether you consider extramedullary disease, high-risk cytogenetics, tumor burden, bridging therapy, revised ISS, prior regimens. In all these cases, the CAR T cells directed against BCMA, the BB2121 ID cell construct, are really proving to be effective. But maybe we can even make them more effective. And this is another quite similar construct, but actually focusing on specific T cell phenotypes for the manufacturing of the CAR T cell. So this is the BB2121-7, which actually correlating the expansion and duration of response with the T cell phenotype. And actually, these preliminary data are suggesting that the enrichment for memory like T cells may improve the clinical outcome. So, I mean, this is quite fascinating because remember, the previous study is not, BB2121 is not yet approved. We hope to have an approval during 2021, the year 2021, but actually you have already some advances trying to further optimize it. The other highly promising and quite impressive construct, in my opinion, is this construct called now cilta-cel, and described in this CARTITUDE-1 trial. So CARTITUDE-1 has been previously presented, and here we had a very nice update, and you can see that the overall response rate is 97%, and the overall rate of MRD negativity is extremely high, more than 90%. Obviously, we can debate about the value of early MRD measurement, about sustainability. I insisted earlier about the issue of sustainability. Nevertheless, these CAR T cells, the cilta-cel, apparently are extremely powerful. Of course, comparison, cross-trial comparison is not allowed, but I'm very excited about these results, especially when it comes to the safety profile for CRS, for instance, where we mainly see grade 1 and grade 2. Neurotoxicity has been observed, as it is the case in CAR T cells, and 10% has more than a grade 3. And we need to dig deeper to better understand these cases, but definitely cilta-cel is the new comer, which will, in my opinion, make a big difference in the field of cellular therapy for multiple myeloma targeting BCMA. But actually, you can also target 2 antigens, dual targeting. So if you want to further improve the results of targeting BCMA, why not targeting 2 antigens? And this is exactly what has been done in this presentation, where you had a dual targeting of BCMA CD19. Again, of course, these are rather small studies, single arm, but it's a very convincing proof of concept. First, about the feasibility. Second, about the safety. Third, about promising outcomes being shown. So I think in the future, similar to what is being done in lymphoma, actually, where we have also many trials having dual targeting, actually, this is coming into the field of multiple myeloma. But actually, these were autologous CAR T cell. So you need to do apheresis. You needed 3 to 4 weeks for manufacturing them and then reinfuse them. So that can be problematic in some patients who cannot wait. So logistics can be an issue. Well, how to circumvent this? Well, this is about allogeneic CAR T cells, where you can use healthy donors and actually prepare them in advance. So off-the-shelf an off-the-shelf product, CAR T cell product. So totally important innovation. And actually, these allogenic CAR T cells, their use has been established in the field of acute lymphoblastic leukemia. And by the way, the initial phase 1 trials were just published this week, 2 days or 3 days ago, in the Lancet. And I was happily surprised to see during this ASH 2020 the first result of an allogenic CAR T cell in multiple myeloma targeting BCMA, but also anti-CD52. But for the sake of time, I will not go into the details why targeting anti-CD52. Nevertheless, these results are quite promising. And I must confess that initially I thought how it can make it with allogenic CAR T cells, but these results are definitely showing the feasibility, and this approach needs to be further refined, but this is a good start, good proof of concept. The second big family in terms of immune therapy is about the antibody-drug conjugates. I think most of you are familiar with belantamab, targeting BCMA and linked to mafodotin. It is approved and it's being extremely useful to a lot of patients with relapse refractory myeloma. So we're glad having it. But during ASH 2020, we have a newcomer, a new agent. The code is MEDI2228. I guess this is MedImmune 2228. Phase 1, dose escalation, but definitely very promising results. An overall response rate, 66% in triple class exposed relapse refractory myeloma. The big problem we're facing with these antibody-drug conjugates, whether belantamab or this MEDI2228, is about the ocular toxicities. The features are quite different in belantamab. With belantamab, it's more about keratitis, which can be reversible actually in many, many cases. And I believe we will have progressively tools to mitigate it. With this MEDI2228, it's more about photophobia. And here it's more difficult to be mitigated. So we need really to dig carefully. But I think these results are really promising because we know that the antibody-drug conjugates are really very powerful agents in many hematologic malignancies. Remember gemtuzumab in AML, acute myeloid leukemia. Remember inotuzumab. These are approved, widely used in acute lymphoblastic leukemia. And I think we will see this more and more in multiple myeloma. Third big family in immunotherapy for multiple myeloma are really the bispecific antibodies. And it's a true fireworks during ASH. I could count 8 different agents, 8 different presentations. Many of them are targeting BCMA, And I selected this one because I thought the teclistamab data are really very attractive. You can see the results. And what is attractive here for me is that you can use it subcute. So this is very interesting, making it very convenient. And you can see the swimmer plot here that you have some long-term responders, whereas these are patients who failed 5 median prior lines of therapy. Some of them went up to 11. And the safety profile, especially when it comes to CRS or neurotoxicity, actually were quite acceptable. While many bispecific antibodies are targeting BCMA, one may wonder whether you would like to switch gears and use another target. And this is exactly what has been done here with talquetamab, which is another bispecific antibody targeting GPRC5D. Very strong data, 69% overall response rate with VGPR in 40% of the patient. We're talking about patient heavily pretreated, median of 6 lines of prior therapy. Looking into the safety, you can see that CRS was generally low grade with no grade more than 3, especially with the subcute dosing. Median onset was very short, but the median duration was also very short. And we're looking forward to more data in this field. For the sake of time, I'm not presenting all the data from antibodies bispecific, but I wanted to highlight, for instance, this AMG 701 called T-cell, another bispecific directed against BCMA. And you can see, again, we are in phase 1 data, but the overall response is more than 80%. Again, similar to the previous studies, 6 lines of prior therapies, and you can appreciate this amazing patient who is long-term responder with stringent CR. So definitely the bispecific T-cell engagers are here to stay. One last one, because otherwise I will spend the whole evening talking about bispecific. I thought this one is also very attractive because it's exploring another target, the FcRH5 as an antigen. So I'm sure you will hear in the future about this one, cevostamab. Phase 1 data, bispecific, but clearly very good overall response rate in heavily pretreated patient, very good safety profile. I still have 1 minute, and although this is dedicated to myeloma, I thought I needed to highlight one slide about the DARA VCD trial in amyloidosis. We know that amyloidosis is an orphan condition. Nothing is approved in this condition, and the outcome of these patients has been very dismal for many, many years. Thanks to some pioneers like Dr. Merlini, the natural history of amyloidosis has been transformed over the last 10 years. And I think this combination of daratumumab, bortezomib, cyclophosphamide, dexamethasone, validated in this Andromeda phase 3 trial, is really a breakthrough and will be extremely impactful. I think you can see the colors and the bars. I don't need to spend a lot of time to convince you about the superiority of this quadruplet. But if you want to dig deeper, I saw this week that there is a wonderful review article just published in Blood. You may wish, if you have time during the vacations, to read it a bit. So this is my last slide. As you have seen, the field of multiple myeloma continues to dominate all innovations in hematology. This is definitely the myeloma is a superstar, and we are really very proud. The myeloma community never gives up, and more options will be available to patients. And I would say we would need more and more combinations. Also, it can make it more difficult to see how to adjust this to clinical practice. Still, having more options is always good news. I would prefer to struggle with more options, more drugs, rather than having no options. But also, I believe the future is looking more and more brilliant for the myeloma patient and their families. Remember the 30-35% plateau long-term survival at 10 years in the transplant population with all generation of drugs. So you would imagine with quadruplet combination that can be further improved. So I think we don't need to predict the future. It's being created right now. So with this, I'd like to thank you all for your attention. I'd like to wish you a Merry Christmas, Happy Holidays, and all the best wishes. And I hope that the next year will be 2021 will be better than 2020. And for now, I will try to take your questions. And we do have a lot of questions. I do apologize if I may not be able to take all of them. We still have 9 minutes remaining as part of this webinar. And so let me have a look. Please allow me 1 minute to have a look into the questions that have come into the chat. So where we are, questions, yeah. So one question is about lenalidomide refractory patient. So do you prefer, so there are several questions, so I'm trying to summarize and group them together. Do you prefer the antibodies plus carfilzomib dex combination or antibodies plus pomalidomide? And I think the questions are mainly referring to the Apollo trial, to the IKEMA trial, to the ICARIA trial, and to the Candor trial. I don't think we have a short or easy answer to this. And I think both options will be useful in my opinion. Obviously, some patient may not be able to tolerate carfilzomib, and definitely we will have to go into an Imid-based option like pomalidomide. If for some reason you prefer oral drugs, then definitely pomalidomide can be an option. However, I don't think we have strong arguments to say, well, we should use this or this or this. I think age will have an impact, frailty will have an impact, comorbid conditions, especially cardiovascular problems, will have an impact. Thrombosis history will have an impact, and so on. High-risk cytogenetics, we know that carfilzomib is a very good option when it comes to high-risk cytogenetics. We have other questions about, in this same line, about differences between daratumumab and isatuximab. I must confess, I don't know the answer, because we have definitely, these are two different antibodies. So you have differences in terms of mechanism of action, in terms of the construct. The problem, and this is where I'm ignorant, whether all of these subtle differences will translate into a meaningful clinical difference, because there is a gap between having different construct, different mechanism of action, and whether this is useful in the clinic. For the time being, I think whether you use isatuximab plus Pomdex or daratumumab plus Pomdex, or whether you use isatuximab plus carfilzomib dex, or whether you use daratumumab plus carfilzomib dex, actually, these are really good options, and they have been validated in randomized phase 3 trials. So this is quite strong. We have a lot of questions about MRD, and of course, I insisted a lot on MRD. So what, in your opinion, the most reliable method to detect MRD? I'm not an MRD expert, so I can only verbalize what I hear from the expert. I think there are two major methods which are well established, well validated. The NGS, which is also, by the way, approved, I think, by FDA. The technology are relatively easy, straightforward, and can actually allow you to go into a very deep threshold, 10-6. And I believe 10-6 is really the one we should look for, in addition to sustained MRD. And then you have multicolor flow cytometry, which has been standardized thanks to the EuroFlow project. Obviously, flow cytometry is available in any hematology center, I would say, or hospital. It may be more difficult to go into the 10-6 threshold, and it may require more events, and the quality of the material can be an issue, etc. So I think, depending where you are, what are the options which are available? I thought NGS is easy, very quick, straightforward, but definitely flow cytometry can be a good option. We have a good question here about the approach for young patients in resource-constrained countries with limited options. Cheapest approach. Well, this is a very difficult question. And we are here in an IACH webinar, International Academy for Clinical Hematology. And we are really a global organization lobbying and struggling and pushing for availability, accessibility, and affordability of drugs. We believe all myeloma patients deserve to get the best treatment everywhere. Of course, this is not something physicians and medicine or science can control. Our role is to bring these new combinations, to bring these new agents, to validate their use. And the reimbursement, the approvals sometimes are beyond our power, unfortunately, because otherwise, if it was to me, I would make them available for everybody for free. That's clear. So the approach, I think, a triplet induction with VTD or VRD. If you're asking me about the cheapest, well, VTD is cheaper than VRD. Auto, even double auto, we know that the cost of auto outside the United States is really very reasonable. And when I look to the data long-term follow-up at 10 years published by Dr. Cavo in Lancet Hematology 6 months, a few months ago, actually you have 34% PFS at 10 years. So even with a first generation, relatively affordable approach, you can achieve long-term outcome. I hope I have answered your question. We have an interesting question here. What do you think about the use of melflufen will be in myeloma? Well, very good question. Well, actually, I'm quite optimistic about the use of melflufen. Of course, you may think, well, alkylating agents are old-fashioned, and now we have to go to the fancy new drugs and to the antibodies, to the immune therapies. Well, that's true. But then if we look, and when I ask and speak with colleagues, actually we have less and less patients who are receiving alkylating agent in the beginning. So alkylating agent, and specifically a new generation alkylating agents, the peptide conjugates, can prove extremely useful in those patients who are naive from alkylating agents. This is why, given the available results of melflufen on the Horizon trial that I mentioned, just published in JCO, the first result of the Anchor trial and many other ongoing trials, I believe alkylating agents are here to stay. It's more about the sequence, and some agents will move into earlier lines, for instance, the bispecific, probably CAR T cells, and some agents will move into a later lines. I don't believe at this stage and today one can claim, oh, I don't need this drug, or I don't need this, or all of them are useful. This is why I'm quite optimistic about the role of melflufen. We have a similar question, actually, I can see on the dashboard about selinexor. Well, I didn't show data about selinexor because, well, I have to do a selection and what I thought would be the most attractive. However, I personally believe that selinexor is also a good drug that can be useful in many patients. The problem is that you will never find a single drug that can fulfill the needs of every single patient. So we need to fight and make all of these drugs available. The mechanism of action is attractive. Safety profile can be managed, and we see now compared to single agent use of selinexor versus combinations, when decreasing the dosage, definitely combining selinexor with bortezomib, for instance, is attractive in many patients, because please do not forget that we are facing more and more patients who are becoming refractory to antibodies, refractory to Imids, refractory to CAR T cells. You know, they continue. Also, I'm enthusiastic about CAR T cells, but the majority of the patients are progressing after CAR T cell. So you need to find options, and we need to stick to these options and push them forward. And it's the same, actually. I have just now, while I'm talking, a question about belantamab. Well, for me, it's exactly the same answer, the same story. Belantamab, I believe, is here to stay, and we have to refine the use. I always remember, you know, the bortezomib story in 2000, 2001, 2002, and peripheral neuropathy. I can assure you that that created a lot of concerns, peripheral neuropathy. But now everybody knows how to use bortezomib. We have further refined the use of bortezomib, switching to subcute, etc. And bortezomib now is a pillar of the treatment. So we need simply to give time to these new agents to be, it's a learning curve, to be better understood, better integrated into the landscape. But I think we are on the right track. I'm looking again to many questions. I must confess, I'm not able to get all the question because the dashboard is full. We have a good question here, whether we should treat biochemical relapse after auto or whether not. Well, this is a $1 million question. The tendency these days more and more is to treat early. I cannot answer whether, you know, if the patient was in complete remission and you suddenly see a positive monoclonal component of 1 gram, that you have to jump in and start your combination. I think if it happens today, I would definitely allow this patient to enjoy a good Christmas holiday. So you have to adjust to personalize. The only answer I can give to you, to the colleague who asked this question, Dr. Alwan, I think I'm reading, is that you have to personalize the treatment approach. And I think clinical judgment is really the most helpful. I do apologize. There are more and more lots of questions. Thank you all for joining us. It is very nice to be with you tonight through this webinar. I'd like to thank you for being loyal to the webinars of the International Academy for Clinical Hematology. Please do not forget our different activities. The journal club every 15 days, and the next journal club will be early January. We'll have a break now, you know, during the Christmas and end of the year holidays. We will have also other post-ASH updates, one dedicated to cellular therapy by Professor Savani from Vanderbilt in the US. We will have also a post-ASH dedicated to allogenic stem cell transplantation by Professor Arnon Nagler. This will happen in January, so please look into your email box and to register. All of these activities are given free of charge, of course, and this is the non-profit spirit of the International Academy for Clinical Hematology. For the time being, I need to close this webinar. I hope you have enjoyed it. I hope it has been useful. Wherever you are, thank you very much. Please stay safe and keep well, and happy end of the year, and hope to see you in great shape in 2021. Goodbye.